Today in this video, we are going to see the introduction to the treatment of testicular carcinoma. There are many different treatment options for the treatment of testicular carcinoma, like surveillance, chemotherapy, retroperitoneal lymph node resection, depending upon the seminoma and non-seminomatous status, and also depending upon the risk group classifications. Okay, so today we are going to see the what are the treatment options and the difference between seminoma and non-seminoma, and some of the things which you should know before going to the treatment. So what are the options which are available? The options which are available are surveillance and chemotherapy, and also RPLND, retroperitoneal lymph node resection. This chemotherapy is given to the carcinoma patients regardless of the decrease in the WBC count due to the chemotherapy, or increase in the creatinine, that is nephropathy. Even in moderate to severe nephropathy, we used to give severe CKD. We used to continue giving this chemotherapy despite the patient having a rise creatinine, and also decreased WBC count also. We should continue to give on this chemotherapy. Continue to give chemo. Same like chemotherapy, this RPLNT should also be done aggressively. In spite of metastasis to multiple areas, this RPLNT should be done aggressively in testicular cancer. The reason for this aggressive approach is that the testicular cancer, if appropriately treated, can be cured. Next, the important thing to consider is that to contrast between seminoma and non-seminoma, because the treatment varies for these two. So why we should differentiate seminoma from non-seminoma is that seminoma has a good prognosis, that is favorable natural history. Seminoma is less aggressive. It is diagnosed at an early age. The spread is predictable by lymphatics. It is sensitive to chemotherapy, platinum-based chemotherapy, and sensitive to radiotherapy. It is one of the tumor which melts in the radiotherapy. So radiation is the treatment of choice for clinical stage 1A and B seminoma. And moreover, only 15% of cases of seminoma have a rise in beta hCG. So tumor markers are not used as a guide in treatment decision. In seminoma, but for non-seminoma, this tumor markers is very important for the treatment for non-seminomatous germ cell tumors. The thing about malignant transformation of seminoma, that is especially the seminoma rarely can transform into a teratoma. This is not much important in seminoma, but for non-seminomatous germ cell tumor, transformation to teratoma is very much important, because the treatment varies for this kind of transformations. And moreover, in non-seminated germ cell tumor, the risk of teratoma at metastatic site. If there is a risk of teratoma at the metastatic site, the patient should undergo RP, L&D, lymph node dissection, that is surgery. Why I am stressing this teratoma is that the teratoma is not sensitive to chemotherapy. So, if there is a teratoma in the retroperitoneum, the only treatment is surgery. In non-seminated germ cell tumor, okay, it is mostly a mixed tumor. As I have told before, testicular carcinoma can be cured. We should use a combined approach of chemotherapy and surgery for the treatment of non-seminated germ cell tumor, because this chemo will take care of the chemosensitive elements, and the surgery will take care of the teratoma component. And also the other thing to note is that SMN, secondary malignancies, and also cardiovascular diseases in testicular carcinoma patients, because these testicular carcinoma patients are more subjected to chemo, RT, and repeated CT. So these are also the things which we should take into consideration in the treatment. We have seen much about GCNIS, that is germ cell neoplasia in situ, in our previous videos. So for GCNIS, we have 3 options for treatment. These are orchidectomy, and low dose radiation therapy, that is more than or equal to 20 Gray. The reason for giving radiation therapy is that Leydig cells are chemoresistant, radiation resistant. So testicular protection is not much impaired in this radiation, around 20 Gray. Radio resistant. Leydig cells are radio resistant when compared to other cells in the testis. And the other treatment option is observation. How we should diagnose GCNAS? This is diagnosed by testicular biopsy. We have already seen the indication for contralateral testicular biopsy. So these are done only in patients with risk factors like atrophic testis, cryptorchidisms, etc. Another thing to note is that why we stress much about GCNS is that it has a 50% risk of transforming to germ cell tumor within 5 years. That's the reason we should decide whether to treat this GCNAS or not. We are going to see the treatment of non-seminated germ cell tumor. At first, let's see the treatment of clinical stage 1 non-seminated germ cell tumor. Clinical stage 1 means that the tumor is limited to the testis. What we will do after orchidectomy, okay, high inguinal orchidectomy, we are going to see the treatment options. So what are the treatment options available after high inguinal orchidectomy? So for testicular cancer, we will do a high inguinal orchidectomy. So after that, let's see what are the treatment options available. So the treatment options available are surveillance, Now we are seeing only the treatment options for clinical stage 1. Clinical stage 1 non-submucous germ cell tumor. So the first treatment option is the surveillance, second treatment option is the retroperitoneal lymph node dissection, third treatment option is primary chemotherapy. If you are giving chemotherapy straight away for the first time, it is known as primary chemotherapy. Okay. So these are the treatment options available. For all these treatment options, the long-term survival reaches 100%. Long-term surveillance reaches 100%. So since the long-term surveillance is 100%, 100% in each individual treatment of in this stage, so there is a controversy. Which treatment options we should provide? So there is a controversy in that. So let us see how to overcome this controversy and how to decide the treatment option for this clinical stage 1 tumor. The risk assessment for this tumor that is based on the risk of occult metastasis. The treatment option depend on this. So the treatment option depends on the risk of occult metastasis. So we have diagnosed a testicular cancer to be as a case of clinical stage 1. So how to decide the treatment approach? First, we should see the risk of occult metastasis. So what are the risk factors for occult metastasis? There are two risk factors. One is lymphovascular invasion. The second is embryonal carcinoma components. If these two are there in the specimen, then we should consider either retroperitoneal lymph node dissection or primary chemotherapy. If the patient doesn't have any of this, then we can opt for surveillance. Simple as that. So let's discuss something about each of these individual treatment options. Okay. So coming to the surveillance, the rationale for using surveillance is that up to 70 to 80% of clinical stage 1 non-submucous germ cell tumor is cured by orchidectomy alone. So what are the disadvantages of surveillance? First, we are giving a chance of relapse. Relapse may happen. There is a need for long-term surveillance more than 5 years. So these patients, we are subjecting the patients for repeated CTs, and there is a risk of secondary malignancies, secondary malignant neoplasms. Suppose if the relapse happens, the treatment also is very difficult for these cases. Okay, not very difficult. We are giving a much more intensive therapy for relapses. So the risk of intensive therapy is also there if you are leaving the patient for surveillance. So if the patient gets a relapse in surveillance, there are two options available. The straightforward option is primary chemotherapy. This is not called as primary chemotherapy. This is called as induction chemotherapy. So if there is a relapse and then we are giving a chemotherapy, that is known as induction chemotherapy. Most of the relapses occurs in less than 2 years. Okay. And another scenario is that if the serum tumor markers are normal and if the retroperitoneal lymph nodes are less than 3 centimeters, we can go in for RPLND, retroperitoneal lymph node dissection. So in surveillance, these are the disadvantages, and there is a risk of relapse, and we have seen how to manage this relapse. So coming to retroperitoneal lymph node dissection, okay. So what is the rationale for this lymph node dissection? Retroperitoneum is the most common site of metastasis. 15 to 25% of clinical stage 1 non-seminomatous germ cell tumor have a risk of teratoma. There is a low risk of recurrence. Low recurrence because we are removing all the lymph nodes, metastatic lymph nodes. There is no need for chemotherapy and the comorbidities related to the chemotherapy. Since we are removing all the lymph nodes, metastatic lymph nodes, there is a high cure rate. And there is a high salvage rate after relapse. So there is a less chance of relapse. If relapse happens also, there is a high rate of salvageability. We can salvage easily by giving induction chemotherapy. As the surgical procedures have improved a lot with the invent of nerve sparing techniques, there is a low morbidity nowadays in highly experienced centers. Let's see the disadvantages of retroperitoneal lymph node dissection. First of all, it is a major surgery. So surgery related comorbidities in malignant patients are there. The experience of the surgeon is also important because if we have not removed the lymph node completely, there is a risk of relapse and there is a high chance of double therapy. Double therapy means giving doing the surgery and after that giving the chemotherapy. Let's discuss some points regarding the primary chemotherapy. So what is the rationale for giving primary chemotherapy? There is a low chance of recurrence. Low chance of relapse. But if the relapse happens, then the patient is in danger because it is less amenable to salvage therapy. Because these relapses are hemoresistant. In testicular tumor, the chemotherapy is considered as a very precious treatment option because whatever fails at the last resort, we will go for this chemotherapy. So we want to use this chemotherapy very carefully. In these low stage tumors, if you are opting for chemotherapy, we are using this highly useful weapon initially itself. So if there is a relapse, there is a less chance of treating this relapse. So this is the reason there is less salvage therapy available if relapse occurs after primary chemotherapy. And since relapse happens, since we have not removed the entire lymph nodes, the patient must also go in for repeated CT in follow-up. So there is a high rate of secondary malignant neoplasms, etc. So for clinical stage 1 non-seminomatous germ cell tumor, the primary chemotherapy which we give is BEP 1 cycle is enough, bleomycin, etoposide and cisplatin.